Okay. So then it goes on to say, you know, anyone have experience with this? And of course, several amazing people chime in and give some perspective. And Sue Doyle comes in and says, you know, there's a clinic in my area that does PT, but then has a trainer for cash-based program around the PT after discharge. Super common situation, right? Continuity program, whether it's provided by the PT, the PTA, an aide, a trainer, an LMT, a yoga therapist, there is no limit on continuity and what could be provided after discharge. There's some limitation based on State Practice Act on what could be provided as a cash-based service within a plan of care. But again, it all depends on kind of the verbiage you're using in your plan of care. So James goes on to ask, any issues with this and Medicare in your understanding? So James, I'm going to nail this down for you based on my understanding and based on a reference I'm going to provide. So James says, you know, my understanding, I have past patients doing personal training right now. Now, are they doing personal training with you, or are they doing it with a personal trainer? And are they doing it as part of a plan of care or after discharge? I'm just curious because these are all clarifications and nuances that need to be addressed. Personal training right now, but I guess I'm hung up on still being a medical condition. So here's the thing. You can't throw a rock without somebody having a medical condition. A medical condition in and of itself does not indicate medical necessity. So keep that in mind. Like pain does not indicate medical necessity. A medical condition, a diagnosis, the diagnosis alone, this is a direct quote from Medicare guidelines, the diagnosis alone is not enough to justify medical necessity. So don't let that get in the way of your final decision. It's a component of your decision-making process, but it's not what the decision is based on. And so then you go on to ask, and let me find this other section here. James says, I guess my question really is, when would you consider treatment for Parkinson's patient truly not medically necessary? So let's get into this a little bit. And, you know, again, sorry guys, I'm not sharing my screen. Hopefully you guys are on and able to watch. Looks like there are a couple people on. So I'm going to grab, what I'm going to do is I'm just going to copy and paste this straight into the post for those of you who are here. So you should see it come over in the comments. And basically what it says, this is straight from Medicare, page 177, Medicare, CMS chapter 15. So it says, you know, an outpatient scenario in which a patient has not been receiving ongoing therapy under a therapy plan of care needs a maintenance program. So this is kind of your situation where, you know, that individual gets referred to you. They've been diagnosed with Parkinson's. Maybe they did therapy, maybe they didn't. They're not in a plan of care, right? But you have this program, which I think is an amazing idea. And I think we need far and far more people doing this. People are just hung up on the guidelines, you know, and compliance and what are we allowed to do. And so we go to the Medicare regulation to clarify how we make our decisions. So in this example, okay, a patient with MS needs a maintenance program to slow or prevent deterioration in communication ability caused by the medical condition. Now you specifically said medical condition, right? Granted, this is speech. I think you're a PT, but the same rules apply. So therapy services from a qualified speech therapist, switch that to physical therapist, may be covered to establish a maintenance program, even though the patient's current medical condition, I just lost it. Current medical condition does not yet justify the need for individual skilled therapy, evaluation, establishing the program, training the family or support personnel may require the skills of a therapist and would be covered. Note, in this example, the skills of a therapist are not required to deliver, actually carry out the maintenance program services, and as a result are not covered. So James, I think this is where we're getting into, okay, where's the line, right? And how do we establish that line? Now, a common retort to my message is, well, Tony, you can justify anything. You know, for 2 decades, you were on the in-network participating provider side. I'm sure I justified everything as being medically necessary, reasonable. You know, I spent decades just looking and digging into the research to justify continuation of care and delivery of services as covered services. Now, all of a sudden, I'm doing a 180 and I'm saying, well, wait a minute, maybe it's not all medically necessary. And mind you, this is what I think people are missing. The people who don't know me and don't hear the past content and how things have changed for me over the last couple years. I'm still providing covered services. I'm still a participating provider. I'm not really selling cash services, right? I think I should. I think my business would benefit from it. But I want you to understand that the message I'm delivering is intended to come from a relatively neutral party. I don't benefit financially from the message I'm providing. In fact, it's hurting my business because I'm discharging people probably a little sooner than most of the competitors in my area. So I just want you to understand, it's not like I'm trying to, nail this message down because I'm going to make a boatload of money. I'm not. I'm going to hurt my own business, but I'm trying to clarify the waters for you guys. So back to your question, James, I think the difference is in the guideline, whether it's you as the physical therapist delivering the service on a cash basis because it's not medically necessary, or a personal trainer or a PTA or whomever you have that you've determined can provide this service safely within a group setting, a class focused on Parkinson's. Like I've been boxing my entire life. I love the boxing and Parkinson's programs. I love the stuff that is out there because I think that's what these individuals primarily need. Now, I also understand there is a spectrum, right? Because that's the other thing that people always come at me with is they're like, well, my Parkinson's patient, has all these cognitive deficits and Alzheimer's and dementia and all this other stuff. Then they're not appropriate for an outpatient group program. That's fine. Like that person needs one-on-one skilled care. I get it. But there's a lot of people who don't need that, and they shouldn't be deprived of the ability and the opportunity to work with individuals for self-pay services. And so I think the first thing you need, James, is you need some sort of criteria to establish, okay, person reaches out to me. We start communication, even right over the phone. And I develop a checklist of maybe my 10, top 10 questions to ask to establish, is there a need for therapy? Is there medical necessity being, communicated here? And so maybe it's something like, tell me a little bit about your current level of function. Tell me a little bit about your day. What are your hobbies? What things do you do? Do you enjoy? Do you drive? What medications are you on? I start the pre-admission process over the phone. And so if the individual is bathing, grooming, dressing themselves independently, right? Okay, so maybe that's question number one, moving me toward, it doesn't sound so medically necessary. Well, what comorbidities do you have? What other things? Are you hypertensive? Do you have diabetes? Do you, height, weight, any of those factors that you believe as a clinician are important? And they start answering those questions. Okay, yeah, I'm diabetic, but I check my blood sugars daily and I'm on metformin, my doctor is supervising it. Okay, so on that spectrum, we're moving toward less demand or need for medical necessity, right? Now, if they were back over here and they're like, well, I don't know, I've been admitted to the ER several times for, high blood sugar, and I'm not on medication, and I am hypertensive, but I don't, manage it well. Okay, now we just moved over to the medical necessity side of things, right? Or they just had an MI and they're on cardiac precautions, or they just had surgery. I think you can start to see as you're communicating, if they're independent in the community, they haven't had any falls, in the last 12 months, they're going to church, they're active at home, they're active around the yard, they're doing gardening and all these things. You can pretty well pre-screen them to determine where they should be, right? Now, let's say you make a mistake. because I think this is a common concern. You're talking to this person sounds outstanding over the phone. They come into your clinic, you're ready to set them up with, you know, the independent Parkinson's program, because they're going to get strong and they're going to get balanced and they're going to get all these things that your program delivers. And all of a sudden you see them stumbling as they come into the clinic, and you see them struggling to stand for 2 or 3 minutes while they're talking to the front desk, and you see them, you know, altered gait and assisted device and all these other things. You stop the process right there, and now you say, hey, this isn't the same situation. You're thinking to yourself that I heard over the phone. I think we need to go a different route. You know, now there's lots of programs that will, if you're a PAR provider or non-PAR provider, you're contracted with Medicare. The normal course of action would be you provide a skilled evaluation. You bill it through Medicare. You establish a plan of care that includes your non-supervised, independent, not medically necessary Parkinson's program that is paid for on a self-pay basis. But then there's also the plan of care running in the background. So you complete the medically necessary initial evaluation, develop the plan of care, which includes the Parkinson's program. You do periodic updates to that evaluation and plan of care, you know? So maybe you're going to get them in, you're going to do the covered service eval, they're going to do the program for a 6-week period. And at some point between the 5th and 6th week, you're going to grab them, you're going to bring them back in, you're going to do a version of a progress note where you assess where they are, what they've been doing, what their challenges are, what deficits they still have, make tweaks to the recommendations you had in the original plan. You're probably going to talk about stuff they could be doing at home to supplement what they're doing in the Parkinson's class. You're going to be talking about maybe modifications, maybe assisted devices. You're going to be looking at progress toward their stated goals. Those treatments, those sessions, those are covered. Those are medically necessary. Those require your skills as a clinician. I think that's clearly established in the guidelines. But that doesn't mean that you're the one providing the direct, you know, one-on-one care or group care in the program. You're legally allowed to be hired by the patient to provide the self-pay stuff. It's your responsibility as the clinician to say, even though the patient is hiring me, a licensed clinician, does not make it medically necessary, because the patient is safe to do this independently under the direction, you know, guidance, supervision of a personal trainer, LMT, ATC, whomever would otherwise be teaching the class. You just happen to be the one teaching the class. Now, of course, you get into the ABN question. Do you need an ABN for something like this? I would say if you've completed an initial evaluation, created your plan of care, submitted the claim for that initial visit to Medicare, and it was medically justified, but then they're going to be doing the self-pay program as kind of a component of your plan of care, I would have the ABN in place. I would indicate the reasoning and the rationale right there on the ABN. I would not be filing claims for the visits they're doing in the Parkinson's program. So it's more of a voluntary ABN that you're doing to help the patient understand, and you clarify in the documentation why those visits in the Parkinson's program are not medically necessary, not covered services, but yet it's a component of your active plan of care. So James, I don't know, I went a little longer than I expected. Hopefully this video can kind of help you and help others in the group. If there was a hole in the rationale, if I missed something, you know, absolutely let me know what your additional questions are. Because just remember, Medicare CMS has published guidelines that clearly say when a service is not medically necessary, no longer reasonable, that individual, that patient, that beneficiary can hire you, the clinician, on a self-pay basis to provide continuation of services, okay? But in that situation, since it's not medically necessary, not reasonable, it does not follow the Medicare fee schedule, you're free to charge your normal cash rate above the Medicare fee schedule if that's what you're charging. because it really is a different service. It's a non-covered service at that point. So, all right, guys, I think it's Saturday. I'm going to go enjoy the day. If you have any questions, post them here. Otherwise, I'll catch you guys in the next video. Thanks so much.